let's go on. A little less light maybe, or is it possible to decrease the light? Okay, this morning the first topic was immediate placement, immediate aesthetic. We saw the practicability of that. We saw that we need a bone volume and a primary stability to be able to make this protocol. If one of these parameters is missing, we cannot use this issue. We can have bone missing in height, in width. Of course, when the tooth is already missing, the advantage of immediate placement and immediate aesthetic are not the same because we already lost the emergence profile. We have cases like big cyst, apical. In such a case, our VOTA, as I explained this morning, is not enough. We have not bone enough beyond the apex to get the primary stability. We can lose the complete buccal wall of the socket because you must know that a root fracture is an emergency. In my clinic, I have protocols, and my referents know that if there is a root fracture, I try to be able to operate the patient the day of the trauma. Because after 2 days, bone is gone because of infection, because of the bacteria. So, and you are like that. It's going very, very quick. Or what can happen is when you remove the tooth, maybe an ankylosis, or maybe bad movement, and you crack. Anyway, when this happens, you have to change the issue. You have to find another possibility. But what I would like to say too is, just to conclude the first topic of this morning, that I always tell to my patient, when I planify an immediate placement with immediate aesthetic, I always tell the patient, you will get a fix tooth the day of the surgery. That's my promise. 95%. It's not 100%. Oh, doctor, but if you can, what happens? If I cannot, you will go out without your teeth for 1 day. We will put a mask and we make a movable partial prosthesis. So the patient knows that there is no 100% success or not success, but rate to achieve the immediate aesthetics. Because we make all the planifications, but one of the most difficult is to feel the bone density, and sometimes with not enough primary stability. So, that's all. Now, when bone is missing, we have alternative and we have the issue what I call the delayed approach. That's the opposite of immediate approach, of course. I used to work with autogenous bone and block grafts. So more than 30 years ago, that was my gold standard. I said at this moment, when I did conferences, oh, autologous bone is the gold standard. You make a bone graft, a block, you screw it, and you have the best results. On a physiological point of view, okay, but if you now integrate, if you look to the aesthetic, we see that these old techniques, for me, these old techniques are not yet the gold standard, and I will show you. Where did we harvest? For little cases. For the big cases, when we had the full arch to augment, we harvested bone from the carvalho. I worked with a surgeon, which he was harvesting the carvalho, and I was putting the blocks in the mouth. I stopped it because now we have alternative issues. But for much little cases, the donor sites for the bone grafts were the symphysis area, the chin, and the ramus on the lateral aspect of the jaw, lower jaw, where we had the femora. Symphysis, we harvested the block in this area. We had to be careful with anatomic landmarks. The two mental nerves emergencies, of course, the apex of the anterior teeth, and the basal bone. So we had to be at least 3 millimeters of the mental foramen, 3 millimeters of the apex of the teeth. And careful because the cuspid are longer than the incision. In the ramus, it's easier, but there is less anatomic difficulties. Other thing that the quality of bone is not the same in the ramus and in the symphysis. In the ramus, it's really a cortical bone, a very dense bone, cortical. In the symphysis, it's cortical and cancellous bone. So this one, you have more osteoblasts, you have more growth factors, but you are also more resorption. And this one, it's more cortical, so it acts more as a barrier. Look at this old case in November 2008. We lose the central incisor, and when we see this incisor, say, what's the problem? The problem is that a very, very big cyst, And such case, I said it was difficult for me to make an immediate placement. Today, I would change, because the tool change and the paradigm change. But we'll see that this afternoon. But in this case, at this moment, we had no other issue than the delayed approach. And one of the issues I used at this moment was autogenous bone in block that we harvested from the symphysis. As I told you, look, it's a very good bone, a very good quality, because you have cortical bone, not too dense, and cancellous bone. You have a lot of growth factor, a lot of cells, a lot of osteoblasts. That's just on a biological point of view, on a physiological point of view, it's very, very good quality bone. And we put it, the blocks and the top, and we make like an augmentation with the blocks, with the screws. And then we let it heal about 4 to 5 months. Then we put in the implants in a submerged technique that we let heal about 5 months, already 1 year in time, if you add the both surgeries, and then uncovering temporary crown, healing time, and the result prosthodist, which is for the big defect at the beginning, not too bad. But as far as you are doing flaps, and here you have no choice, you have scar tissues. Look, we have, if you see very near, that we have a scar tissue. And today, some patient says, that's not good. It's like that. When we have no choice, we have no choice, but we must know that. And it will be all the topic of this afternoon. Second on the side, the ramus. The ramus, you have to be careful with the angular nerve, of course, but also with the roots of the lower molar. Let's see this case of a young lady. It was 14 years ago. She did orthodontic treatment. She had lateral agenesia, no lateral incisor, and she had the cuspid at the place of the lateral. Then the orthodontist decided to open the space to allow me to put implants. That's the time when we can start the surgery. Okay, when we open, we have bone, but the width is not enough, because if we put the implant in that position, we'll have fenestration. We have an exposure of the implant, of the apical part of the implant. So, at this time, we harvest it like that. So, that's the technique which was described by the first man described was Craig Mish, more than 30 years ago. Then Fuad Curie changed a little the protocol. But anyway, we expose the ramus, that's the angle with the basal bone here. Then you use cylinder bone with the handpiece, you make little holes. You make 2 vertical landmarks with the burr, and with a bone chisel and hammer, you crack the bone to harvest it. That means that in the ramus, the harvesting is by cracking the bone. Then with a saw, you cut your bone, you adapt it, and you screw it. Healing time, at this time I was working with Vicryl, I think it's 4.0. Today I'm working with monofilament 6.0 or 7.0. That changed, but you didn't have it at this time. That's the healing 5 months later. And now we will put the implant. What we must know that when we put bone grafts like that in block, when you put the implants, the bone is of course healed, but not matured yet. That means that on a mechanical point of view, you cannot load immediately these implants. We need to do submerged technique in this kind of surgery. We have no choice because the bone needs to heal more and more. Second remark, as I told you before, this approach, because you make 1, 2, 3 surgery, so you have more scar tissue. It's like that. Okay. After this healing, and look also the scar tissue. You can see it. We opened and we got a pretty good bone in width to put the implant. This time it was in Astra, I don't remember. Anyway, we put the implant in a submerged pin. We can see here the mark of the bone, the block, as we did. Okay, you can see the healing. As I told you, putting the implant in a submerged technique. Of course, just a little flap. We remove the screws through the gingula to avoid with big flap. And 3 months later, we are at the uncovering stage, and then to put the temporary crowns. Here, the 2 screw retain temporary crowns. And after healing times, with your temporary crowns, you try to play with your homogeneous profile to draw the future aesthetic of the changing. That's what we got as a result, and the referent did a very good job. But as I told you this morning, when I spoke about the sortation technique, you can see you have already bone loss in width. It's like that, but we have lost here on the both sides. It's like that. But that's what I explained when I spoke with the bundle bone and with the sortation technique. Okay, yes, it was not okay. That's the case. 3 months later. So, what are the problems with the bone blocks? First big problem is when you harvest a cheap bone block, you have more than 90% possibilities to cut a part of the incisal nerve. And that means that the patient will lose the sensitive sensation in the lower incisor. That's a problem because you have to explain that at the beginning. And it's a complication that you cannot avoid. If you need bone, you need bone. But that's one of the problems. The second one is that with a block, it's more difficult to draw and to adapt than with particulate of cancellous bone or biomaterial, as we are going to see it in GBR. And we'll see the third reason why I prefer this technique now as bone blocks graft. That's a study from Urban. And if you see the statistics, you can see that with autogenous block, we have more than 26% of morbidity of complications versus 12% with the GBR. For me, that's a reason to avoid the block now. Bone block in all parts. And I prefer this technique. What is, to make it quick and short, the principle of the GBR? It's today we use collagen membranes, membranes were resorbable. That means that it's easier. We don't need a second stage surgery as before with the cortex membrane, with the PTFE. And second advantage of those membranes, if you are against the tooth, no matter, you won't have a reopening because it's a resorbable membrane. It was not the case with the PTFE. If you were against the tooth, you had, in 100% of cases, a complication. What is the principle? This membrane allows the blood supply, first step from the receptor side, from the bone himself, and in the second time from the periosteum. And this blood supply will allow the healing of the new material, which will be totally or partially resolved and replaced by a live bone. Look at this case. It's a young lady. Classical case, she was to the orthodontist. The lateral incisor missing on the right side. She came to me and told her, I don't do anything, you go to the orthodontist, and you can come again and we will have the discussion after you have done your orthodontic treatment. So, he did a very, very good job, and I saw this lady 2 years later to now treat the lateral incisor missing, the right one, and the temp was just with a bunting which was attached to the central incisor. Okay. If we see on the lateral view of the CBCT, we can see we have bone. We have bone, but not enough bone to have our implant in a good axis. If I don't want to augment the bone, maybe to make an expansion, it's possible to make an expansion, but my implant will be like that, and I don't want that. For me, the prosthetic leads the surgeon, and the result leads to the implant placement, and the implant placement leads to what we have to do with the bone. And here we need to augment. The planification, in such a case, we can augment the bone in the same time that you place the implant. It's an immediate placement with the bone augmentation, and that's one of another reason I prefer this technique as bone blocks. Okay, we put the implant, it's an X3 implant, and you can see the concavity. And because of the axis of the implant that I want to have, when we can see the concavity here, when you put the implant, we can see at the apex, we can see the spires. There is a little fibrous tissue that I will remove, and there is a hole. And if I don't augment here, I will lose the bone with the time because of the blood supply. Titanium is a barrier to the blood supply. So we need to augment. It's physiologic, no choice. You can say, oh, I have bone, it's okay. No. 100% failure if you don't do that. That's the sausage technique I will describe to you. The principle is to use the membrane and augment the bone. So we put the implant, we put the corkscrew. We see the step-by-step just after. We put little pins to attach the membrane, and we tense the membrane. The sausage technique, like the name, it's like a sausage. You have to have tension, because this tension allows the body material to be stable. You need a mechanical stability, and this stability you can have it with the tension of the membrane. Then suture, here we needed to put a little more connective tissue to avoid to track too much the flap. Putting the implant at the same time, and healing time from 4 months. That's enough due to the little part of bone augmentation. Second time is uncovering. That's my colleague who do that with a connective tissue graft to have most gingiva and a very, very good biotype. And if you see, it's a very, very small incision to preserve the papillas. Very small incision. That's how it looks like. And then the temporary on the right, he did a crown on the left incisor. And that's how it looks like. Of course, we have a little scar tissue because of the technique, because of no choice, it's like that. But the result is not too bad. And this time with this young lady with a good result. That's, you know, that this scar tissue, you cannot avoid it. As far as you do the flap, you have a little scar tissue. What is the step-by-step? And I changed my protocol. I tried, because to avoid scar tissue, I made the resist incision in a more distal part. So let's see how we do the technique here. Okay. We have to augment the bone for the central incisor here. First of all, we study the case with the CBCT, then planification. And the first incision in such a case is on the top of the crest. You go on the palatal side with the 15 blade. With the 15 blade, you make the first incision on the top of the crest in the palatal part of the, to avoid to be too in the front. You slowly go until the bone. It will be here a full thickness flap. When you arrive to the central incisor, you change the blade to have the sharp and the right part of the blade, and you cut until the, so you have a proper incision. Then you will change your blade. My preference is the micro blade, but you can use a 15C blade, which is with a sharp angle, but the micro blade you cut on the both sides and it's easier, and I love this one. And then you will go in the sulcus. So you start from the papilla, a little palatal side, then on the buccal side, papilla. You can make alternative movement. You go on, and one option, it was to show to you, if you want to avoid scar tissue in an aesthetic areas, is to put the reincision more in the distal part. It's one option that I show you that. Then you cut the papilla. That's very important. To preserve the papilla, you need to cut it very, very correctly until the bone. And you go on the clasp. You look the top of the blade through the gun. It's a little fine. And you will stop here, between the middle of the cuspid and the papilla, just in the middle. And then now, you will do a release incision with the 15 blade. And the angulation is 45 degrees. Not vertical, not horizontal, just an angulation 45 degrees. Okay? And you cut. Okay? Not too big. It's just to have elasticity of your flap. Then you go to the other side with your microblade and you go around the central incisor. Here, we won't do any release incision because we are in aesthetic area. We go back, we must feel the contact. We feel when we cut the PDL and we find the bone. It must be very, very clean. It must be a very, very nice incision. The nicest incision, the nicest result. You go back to the distal. And now, we start to elevate the flap. And now, listen. That's my way of work. I will elevate a partial thickness flap. That means I will split, not a full thickness flap. I will preserve the bone by letting the periosteum and the connective tissue. It takes time. You use a retractor, then a blade. Like when you want to open a fish, it's the same. And slowly you elevate, and then you cut, and then you elevate. And look, the areas where we need to augment the bone while in full thickness flap, the other we still have the periosteum and connective tissue. How have I done that? I splitted all the flap. All the sides was splitted and I was in a partial thickness flap for all. And then, when it was done, I just cut the periosteum in the area where I need to augment the bone, and I removed it. That will be the best results, because I preserve the bone where I don't need to augment it. Okay? You see the concavity. Now, you can see the periosteum which is released, we cried it. Then, we make the protocol, the drilling protocol, classical, for the implant, and you can see that on the buccal aspect, as I told you just before, the bone is too thin not to be augmented. A lot because you have the hole, you have a really thin layer of bone, you will put the titanium and you will lose all the blood supply if you don't augment it. Okay? Different technique now. To get more blood supply, some people use with real little holes to make it bleed. It's an option, but I don't do that because if you look to the histology of this bone, it's a membranous bone, the embryologic origin is membranous bone, and if you see with a microscope, you have a lot of microvessels. So I don't need the bone. So what I do is to crack, to scrape the bone, and it's enough to make it bleed. Because by doing little holes, you lose bone. And I don't want, and not enough bone. It's my opinion. So, okay. Then you can look how it was clean and scraped, and how the rest of the flap is a partial thickness. Split it, and here it's full thickness, where I want to augment. Now we'll use that's BioGuide from geistlich membrane, collagen. That's for the surgery the better indication, no doubt about it. And we use pins, little pins, with that support, and with the hammer you will, like a nail, put them. My protocol is I start to fix the membrane at the apical part. On the buccal side of the bone. So, buccal side, apical part, here, 2 pins. Then, you have fixed your membrane and you can open it like a book. It's fixed. You open it and now you can fill with the biomaterial. In such a case, I will use bovine bone. When it's a biggest case, I mix it with autogenous bone. In very big cases, not the topic today, but in very big cases, I harvest from the chin with microscope pieces of ramus, and then I mix them, I crack it, I mix them with the BioOS, and I have a mixing biomaterial which is osteoconductive and osteoinductive, because I have autogenous bone. What I used to do was macro particles of BioOS, and because they are a little big, I use the hammer to crack it and to reduce the size. Former, I thought that the micro particles were too thin and the macro too big, and I had a size between. I stopped it, it's too long. Now I use fine particles and I stop the big particles. But anyway, it's not very important. We have our biomaterials and we will fill it like that. Okay? And with the blood, we'll have a red biomaterial. Then we will tense the membrane, as I told you before, like when you make a gift. You pull the membrane, and then with the nails, with the pins, you fixed it on the palatal side. Sometimes it's difficult because the patient cannot open so big the mouth, but it depends. But like that, we have a really good stabilization of the membrane. Look how we got the tension, a very good tension. And then we close the flap. And what is important when you make bone augmentations is to be able to close it. It's a little bone augmentation. But when you do a big bone augmentation, if you add just a little tension on your flap, when you suture, it will reopen. Why? Because you pull, and when you make your notes, you see the gingiva is actually white because of the tension. You cut the blood supply, and the gingiva will open. So you need to release that with a blade in the periosteum to give flexibility. And when you close it, it must just be like that without suture. It must be in good position. And then you make your suture. And what we did, and the reason why in the palatal side, with our incision, is I have fought to the next incision to reopen. When I will reopen, I will incision at the same position, and to preserve the papilla will split. That's the reason I'm a little in the palatal side when I make the incision in the top of the crest. Okay. That's what I wanted to show you for the delayed approach, for the GBR. As far as I can, I said, as far as I can, I try to avoid it because that's what I would like to show you. And now we have two possibilities with the time. The first possibility is we can make question answer. And if we make to gain time, we can go further for the third conferences. So you decide what organization, what you prefer, what you want to have, and question and answer. Do you have questions? What do you prefer? Yeah. Okay. Okay. Question? No. Okay. Okay.
Once again, thank you so much, Dr. Claude Ameland, for your lecture. And now we'll come to the Q&A section. Và kính thưa quý vị, bây giờ thì chúng ta sẽ đến với phần Q&A. Và như chúng tôi đã chia sẻ đến với quý vị thì những câu hỏi chúng tôi sẽ chuyển đến cho báo cáo viên của chúng ta thông qua Q&A này. Nếu như quý bác sĩ nào mà chúng ta vẫn chưa gửi câu hỏi về thì ngay bây giờ quý bác sĩ có thể quét mã QR để đặt câu hỏi cho báo cáo viên ạ. And right now we have the Q&A section. We have received many questions from the audience, from like the Q&A form in here.
Okay.
And right now the interpreter and Dr. Nguyễn Minh Quân will help her to ask the questions.
Okay.
Dạ, và thưa quý vị, ngay bây giờ thì phiên dịch viên bác sĩ Nguyễn Minh Quân sẽ đọc những câu hỏi đã được các quý bác sĩ ở bên dưới gửi về thông qua mẫu Q&A form này ạ. Dạ, xin được mời.